Hello, everybody. We are here again for the UROLUTS platform, and we are with two good friends, two members of the guideline panel of the Female LUTS, Professor Harding, who is also the chair, and Professor Arlandis. Thank you for being here. I have seen, and everybody knows that there has been an update in your guidelines this year, and the whole test has been updated. And Chris, can you just summarize what are the changes in the guidelines this year, and which are the changes that are most important in our clinical practice, according to you?
Yeah, so I think with the guideline, the size of the Female LUTS guideline, it's a huge undertaking to update the guideline. And for instance, our literature search unearthed over 1,200 different citations. So the first thing to do is thank the panel for how much work has gone into that. With our panel underlying, we were one of the first panels who advocated for patient representation, and they've been invaluable. So I think the change you will see running through our guideline is the importance and the underlining of shared decision-making at every stage. So a couple of examples of that would be in the stress incontinence sub area. And you know, we have made a recommendation so for things like pelvic floor muscle training, that should be first line, and it should be discussed in the context of all the other treatments at the same time. This is not a stepwise pathway, and the risk-benefit profile underlined, and then obviously you know what the patient's expectations are, you know what the patient's wishes are. So that's been a really good development, I think, in the new guideline. In terms of other things, highlights would include, I suppose, some novel treatments emerging. So one example would be saw palmetto. So saw palmetto has been used for men with lower urinary tract symptoms for decades, but we're starting to see some emerging evidence in the OAB sphere. I think the other probably thing we've looked at, again in the OAB area, is acupuncture. So we were able to make a recommendation based on the research that's come through. And what this has led to is a complete revamp of the OAB section. So I must thank Dr. Nambiar for his work. He led that. And we've looked at evidence levels, low certainty, high certainty, and we've arranged it in that way. So I hope readers will get a lot more out of the guideline by knowing just where that evidence sits. So they've been really the highlights. And I think finally we must make mention of the fistula section. So we've also tried to encourage a classification that should be used uniformly for simple versus complex fistula. And I think that will help research going forward if we can define our patient populations better.
It's really interesting because more and more in the female guidelines and in the male guidelines, we are trying to get the patients involved and make them more clinically interesting and something that can really guide us in our clinical practice and in the decision, and this is really important. For example, yesterday we had a very nice session on male LUTS, and you were there, Chris, and we were talking about obstruction and overactive bladder in men, and we were talking about not forgetting the detrusor, and someone asked why we are forgetting the obstruction in female patients then. And I've seen that you have updated also the management, surgical management of the obstruction in women. So, Salvador, what do you think about this topic?
Well, you are very right, Manuela, because the panel members were very sensible to female issues, and especially that the research done in men is not the same that the research done in women. And we try just to compile all the evidence that we have in bladder obstruction in women. And we realized that there is low evidence in most of the different topics. What we get at the end in the panel just was to give a strong recommendation, especially to classify those bladder obstruction, those patients with anatomical or functional, and for sure to make a good evaluation of the patient from the point of view of the clinical evaluation of physical, uroflowmetry, post-void residual, urodynamics, and in those patients with suspicion of dysfunctional avoiding just electromyography. But when we look at what happens in the management, that at the end is a very important part in management of bladder lead obstruction in women, we realize that most of the evidence is low. So these recommendations are weak, but does not mean that they're important recommendations. Probably the only strong recommendations are for non-invasive treatment, just in those patients with dysfunctional avoiding, just to offer pelvic floor muscle training relaxation. I mean to relax the pelvic floor. On the other hand, all the medical treatments, especially oral treatments like alpha blockers, baclofen, well, the recommendation is weak because the evidence is not strong. And in terms of non-invasive therapies like botulinum toxin and structural neuromodulation, the same.
Yes.
We can just offer only weak recommendations that are the only treatments we have nowadays. In terms of the surgery, the surgery is most of it the same. We need more clinical research to have strong evidence on different treatments, like, for instance, bladder neck incision, or urethroplasty, or in cases of urethral dilatation, or if we move to pelvic organ prolapse, for sure, the treatment of this surgical treatment is an option, but all the recommendations you see is weak, but are common sense. We need to do that, but we need more research. Probably the only strong recommendation we have in surgery is in those patients who has bladder lead obstruction after sling surgery.
Yes.
And you need to release, you need to make any other surgery on this, revision of the sling, and that's strongly recommended. So I think that in the panel thinks that it's necessary more research. I think that it's important just to have a subsection in these female LUTS guidelines in bladder lead obstruction, and just to encourage the rest of the colleagues just to make more clinical research to have more evidence in the future.
Yes, I think what it does is we decided very early that we were going to do systematic reviews in terms of diagnosis and management of female bladder outlet obstruction, because as you say, you can't ignore it.
Yes.
And that set the scene for research going forward. So now people reading our guidelines, they know the level of evidence that's associated with our recommendations. So they need to go away and do the research, and the guideline will only evolve. I think the second point I'd like to make is that it really underlines the importance of a multidisciplinary panel. So on our panel, we have a physiotherapist, we have a urodynamic scientist, and we've got patients, and really they all sort of feed together, because it's the management of female bladder outlet obstruction is so varied.
Yeah.
We need expert opinion on each facet of the management. You know, I can talk about the surgery, Salvador can talk about the surgery, but for pelvic floor muscle training, we need an expert physiotherapist. For urodynamic evaluation, we need a urodynamic scientist, and that's what I think the panel works very well in that regard.
Completely agree. I think in our field, the multidisciplinary approach is essential to correctly treat our patients. You mentioned both of you mentioned the urodynamic test. We know that yesterday the results were presented and the paper came out. The results of the future study. So I want to know your opinion about the results and what you are doing till now in your clinical practice, and is going to change your clinical practice after this?
I think it is. I think it is a practice-changing study. So the first thing, you must congratulate the research team for delivering a study during COVID involving urodynamics, where you have to cough several times during the test, recruiting over 1,000 patients, quality control for urodynamic studies. You know, this is an excellent clinical trial, and it will definitely, in our next update, it will be one of the first studies we're going to look at. I don't think it will spell the end of urodynamics in evaluation. What I was really interested in, and I need to read the paper was only published yesterday, so I need to read the entire document, but what was really interesting for me was I got the impression that the urodynamic arm of the trial, the patients had a slightly more tailored treatment. And I say that for two reasons. Firstly, I think the diagnosis was changed a lot more in the urodynamic arm. Secondly, the range of surgical treatments that were taken up was quite different. So it tells me that although if you look at it at a large group level, there's no ultimate difference. Actually, when you look for some selected patients, they're perhaps getting some more individualized and tailored treatment, and that can't be a bad thing.
Yep.
I agree with you. We have not talked before about this.
No, we haven't.
about this interesting paper, but I agree with you. I think that it's a meritorious research paper. It's a very, very huge research done, and that's important. But I think this paper deserves a deep reading and a deep reflection. I don't think that the conclusions go straight ahead. I think that we need to read the small letters, the small capitals, to see if there is some subgroups analysis that could be very interesting, like you have arrived before. I think that there is a change in the urologic study about what to do after the results. And I want to know, because it's impossible to have all the data on the paper, for sure, but I like to know what this subgroup of patients performs comparing to the whole group after the intervention, because it's very difficult just to know what to do with this patient if I, instead of fixing a stress urinary incontinence, I go straight to Botox. So that's, for instance, that's my point. That's the key. So again, all of these papers are very meritorious, but they all have different discussion and reflection and interpretation of the study, like the value trial and so on. So I think that in my clinical practice, answering your question, I still do. Probably I will still maintain doing urodynamic study before, but for sure it make a change in the clinical guidelines, for sure. But with we need a reflection. We need more time. It's very recent. This paper.
Yes.
So what was really interesting about the trial as well is it's not just clinical outcomes they looked at health economic outcomes and cost effectiveness. And when you work in a public health system, as I do, as the NHS, it's really important. So, you know, I just take my hat off to the research team. I think they've done a brilliant trial. We will discuss for many hours in panel meetings where we go with that.
For sure.
But, you know, it's lovely to see level 1 evidence to be debated.
I want to thank you both very much for this interview, and I hope you will enjoy the rest of the Congress. Thank you very much, and see you soon. Bye.
Thank you.